Welcome back to another video of Socrates Medicine. Today we will be reviewing an approach to acute kidney injury, or AKI. Alright guys, so the first step in approaching an AKI or acute kidney injury is you want to look at the urinalysis. You want to get a clean catch. This way you have less than 5 squamous cells, so it's an accurate representation of what you're looking for. So, or also, if they're in a Foley, they have a Foley, for example, you want to make sure that the nursing staff is collecting the urine from the tubing specifically, not the bag, because the urine in the bag can be sitting there for who knows how long and could skew the actual contents of the urine. So first you want to lay eyes on the urine if possible. On the left, you'll see a depiction of some colors of the urine and what those different colors mean. So for example, you'll see, going clockwise, pink, you'll look at that and you want to think like blood or bacterial infection, traumatic Foley placement. Red, you're thinking blood or things that may cause a medication-induced change in color, such as phenytoin, rifampin, various food dyes, beets, acute intermittent porphyria, for example. The green, you may see this in the ICU. This is an indication for propofol. It's completely harmless. It just turns the urine green. And when you see black, I want you to think of metastatic melanoma. And when you see this purple, or you're going to think of like purple urine or purple urinary bag syndrome, you'll see those in chronic Foleys or those with people who have infection. So for example, the bacteria typically known as like E. coli or Proteus, both of these bacteria break down tryptophan, and it gives you that output of that purplish color that you're going to see. Next, I want you to look at this specific gravity, like little line here. You want to remember that it's just the density of a substance over the density of water. So when you crunch all those numbers out, you'll notice more dilute urine will be around a specific gravity of 1.005 towards the left, while things like contrast or urine with very concentrated solutes, those will make a specific gravity. Your specific gravity will be closer to 1.038. And then lastly, I want you to look at this table. It's going to give you an idea of what the urinalysis findings hint towards. So if you see blood without red blood cells, I want you to think myoglobulinemia or rhabdo. If you see red blood cells, I want you to think about like a kidney stone, glomerular nephritis. Those should be on your differential. When you see white blood cells, you can think of pretty much anything: inflammatory processes, lupus, kidney stones, infections. When you see leukocyte esterase, this is a non-specific finding as well. A lot of people think it's just infection. That's not true. You can see this in a kidney stone as well. However, if you do see nitrite positive, this is a better predictor of bacteria in the urine. And think about kind of what we were talking about earlier with the purple urine. You think about those bugs like E. coli. It's a great example of a nitrate reducing organism. And then lastly, pay attention to glucoseuria. It's not always a sign of just diabetes. You can see glucoseuria in non-specific findings such as multiple myeloma, Fanconi syndrome. You can even see it in people who take SGLT2 inhibitors. So combining your findings with the urinalysis, you can look at the kidney function testing to determine which type of AKI or acute kidney injury your patient has. You first need to define those terms though. So anuria is less than 50 cc's in 24-hour period. Oligouria is less than 500 cc's in a day. And AKI, you're going to have 3 different indications that will lead you towards the diagnosis of AKI. Less than 0.5 mils per kg per hour for greater than 6 hours, or creatinine bump increase greater than 0.3 in 24 hours, or creatinine greater than 1.5, the baseline. Now, I know some of you are aspiring nephrologists, and you guys use a more specific staging, like greater than 1 times the baseline would be stage 1, greater than 2 would be stage 2, and so on and so forth. But for now, let's just stick to the basics. And another like tidbit here that would be beneficial is like, if you have these, you go through these findings, and you have an AKI, you want to ultrasound the kidney, and if the kidney is normal in size and you still have an AKI, despite the bump in creatinine, it's just a basic AKI. But if you go and ultrasound the kidneys and they're less than 8 centimeters, they look shriveled, they're small in appearance, this would be an indication that your patient may have an AKI on top of a CKD or chronic kidney disease. Speaking of ultrasounding the kidneys, this is absolutely something you should do when working up an AKI. So I know there are diagrams that you can Google search and it'll show you pre-renal, intrinsic, post-renal, but I want to encourage you to get away from like memorizing all the fractional excretion of sodium and the FE urea and all that. I want you to focus on like 4 big buckets. And these are the 4 big reasons why the patient may have the AKI. So I want you first to think about volume status. Is the patient hypotensive? Are they perfusing poorly? Or are they retaining volume? Like this would be like you're obstructed. Are they taking certain medications? Or have they had contrast with imaging studies? These are all big causes of AKI, and then you have the more rare etiology. So I'm going to tell you kind of my first step is to assess the volume status. I'm going to get the ultrasound. I'm going to do the bladder scan. If they're retaining, I'm going to place a Foley. I'm going to monitor improvement. This again is like what you classically learned as like the post-renal, if you see that in some of your practice questions. My next step is assessing volume, like looking at the vital signs and fluid resuscitation. The big ones here would be like the hypovolemia, blood loss, hypotension, dehydration, sepsis. These can all contribute to volume down states. Also something you learned is like the pre-renal etiologies. My next step, I would run through the medication list of what the patient's on. So looking for any culprits that may cause aberrant kidney function, including things like vancomycin, cefepime, any and all antibiotics, PPIs, immune checkpoint inhibitors, NSAIDs. These are all, these fall into the buckets of intrinsic and pre-renal etiologies. Then think about contrast. If the patient has undergone imaging requiring contrast, that could be a culprit to the AKI. And lastly, I think about those rare etiologies, things like the vasculitis, cancerous etiologies like tumorilysis, multiple myeloma, emboli, and then like all of those glomerular nephritis, right? That's all the rare etiologies. And although those are rare in practice, these are very commonly tested on the boards as like favorites. And so speaking of like glomerular nephritis, acute interstitial nephritis, and acute tubular necrosis, I want you to look at the microscopy, and that will kind of lead you toward one of those 3 diagnoses. So in the table on the right, you can see glomerular nephritis. It classically has those red blood cell casts. And then acute interstitial nephritis, you're going to have white blood cell casts, but it's non-specific. So remember, like, even pyelonephritis can have white blood cell casts, right? So, but in that case, you'd see like pyuria and the UA and things like this. So it's not specific, but it can lead you towards acute interstitial nephritis. And then lastly, acute tubular necrosis, that's going to classically have those muddy brown casts that you see. And that really should be a good start to approaching AKI both in practice and for the board exams. Just a brief review, I would consider this little slide here, diagram that I made, to be high yield. You want to recall when you're looking at like Bowman's capsule here in the yellow, remember the afferent arterial is constricted with NSAID use, while the efferent is constricted with ACE inhibitors. And the kidney can undergo significant damage if we're constricting both of these arterioles at the same time, simultaneously. So it's best to avoid NSAID use in the setting of ACE inhibitors. And that's a wrap, guys. Please comment if you have any questions or concerns. Again, thanks for watching, and I hope this video was helpful. I'll see y'all next time.